I'm actually curious, because you mentioned the neutropenia and there's some of this in bladder cancer, do you give primary GSF prophylaxis A?
Yeah, it's a great question.
Yeah,
Go
and
ahead,
then do you do UGT1A testing for patients with that SN38?
Yeah, it's a great question. So let's start with the first one. So the first one, I did in the US when it was first developed, and I don't know how it is in the bladder cancer business, but in breast cancer, because we're all taught, I mean, you're younger than I am, you're much younger than I am, but in the olden days, we were taught in metastatic disease, because there really was never any curative therapy or nothing ever improved survival, that really you give single agent chemotherapy and you adjust it, you don't give growth factors. And so that was really, for us older oncologists, that really was a big thing. And so I really just was a holdout. I mean, over time, though, we've realized that if you give long-acting GCSF, whatever it is, your biosimilar, whatever you use in your practice, on day 9, so it's a day 1, day 8 drug, right? So you give it on day 9, you really reduce the fever and neutropenia fairly dramatically. And I think that I've started to do that, and especially in patients who've been heavily pretreated. I mean, bladder cancer, there's a much older population, the frailer. I think it's very reasonable. And in breast cancer too. I mean, by the time people have gotten to sacituzumab, they're fairly sick with metastatic breast cancer. And and we're actually using this drug for estrogen receptor positive patients too, and even later lines that are even more frail. And so I think all of us have really started to use prophylactic long-acting GCSF. I don't use short-acting GCSF. I don't think it's necessary. And I use that in dose reduction. That's kind of how we get around that. But I think with the prophylactic, and we get paid for it. I mean, one of the worries was, that payers wouldn't pay for it. That hasn't happened. We really are able to use prophylactic GCSF on day 9.
Which is really great that it's covered.
Right. And the other thing is that, the diarrhea is also the other big one. And we tell patients to expect it. And when it happens, we're fairly aggressive with dose reduction. Now, the UGTA1 is an interesting issue. It's rare. It's not something we as oncologists really deal with a lot. I guess it's more the seizure disorder neurologists kind of deal with this a lot more than we do. But I think the times I've done it are in the patients who have an unexpectedly severe neutropenic reaction to the drug.
That makes
and
sense.
they'll get UGT1A1 testing. It's why not? I mean, I think that it clearly is something there. It's something to worry about. And actually, I've had someone turn positive on me. And so obviously, what are we going to do if they're responding and they're UGT1A1 positive? Are you not going to give them the drug? Of course not. You're going to give them the drug. But what you do is maybe dose reduce, be very, very cautious again. Even if they have a good performance status and look pretty good, these are the kind of people who, really should get prophylactic GCSF. So.